And we are live.
Okay. Hi, my name's Dr. Trinity Blitt. I am an audiologist in Rancho Santa Fe, California, owner of Rancho Santa Fe Audiology. This is a little bit about myself. I went to San Diego State with an undergrad degree in audiology. There I did a ton of research on otoacoustic emissions. Not sure if you guys learned anything about those, but they're the little cells inside the ear. And I actually focus on what personal music devices can do to the ear in a matter of just an hour. And it was teenagers. So I wanted to look at how loud teenagers are listening to their music. We found just 1 hour can actually damage some inner ear cells. Then I went on and did my doctoral at Arizona State University, where I specialized in cochlear implants. So worked with several neurotologists and also was able to work in the school district. So working with deaf students who were ASL or cochlear implant patients, fully oral. So I got a nice little mix. After that, I moved here to back to San Diego, and now own a private practice, specializing mainly in adults, hearing aids, cochlear implants, and diagnostics.
Great.
That's it.
So she was just telling me a little bit about some of the options for people who choose to have a cochlear implant. And I kind of halted the discussion and I said that I'd prefer you guys to hear that. So I'm just going to ask you to kind of launch back into what we were talking about the patient's age and at what point it ceases to be as successful, if you will.
So culturally, a lot has changed in the world of cochlear implants. Generally now we screen at birth. So we know a child's level of hearing loss by the age of 3 months, generally. By then, we've determined whether or not hearing aids are an option, what the family's thoughts are, and we're usually implanting by the age of 1 and a half. Neuroplasticity, or the brain's ability to withstand changes, is very, very quick at that point. So they're generally able to hear and speak like the rest of us by the age of 2. Those children are going straight into streamlined schooling all the way up, college, doctoral degree, whatever they want to do. Something does change in the brain, and we've learned this from feral studies where children have been deprived of auditory input for years around the age of 7. So if somebody is coming to us wanting an implant at the age of 7, 14, 20, and they haven't been oral their entire life, chances are they're not going to do very well. So some of these cases that you will see where patients do not perform well with an implant, generally it's because of the health of their inner ear and their ability to change with the implant. Also, if depending on the length of your hearing loss, so I know you were studying bacterial meningitis. Let's say somebody had meningitis at 20, decided they wanted an implant at 40. That's been 20 years of the brain not hearing certain frequencies and sounds. Chances of success are very low. And I have about 2 patients I'm working with on that right now. It's a tough road ahead. So, yeah.
Okay, that's actually extremely helpful. So they were just given an assignment, and their assignment was, you are the parent of a young person. We said 1 year old who was diagnosed with congenital deafness. Would you choose to do the cochlear implant or not? And then give me the rationale, yes or no. So I'll be curious to see what they came up with now that we've just heard that at that young age they might actually be pretty successful.
Yeah, and 1 is a good age. This is just generally if we find it at birth. And these kiddos are getting tons of therapies. They're getting speech therapy, occupational therapy, auditory therapy. So it's a whole team approach. So a lot of times they end up doing better than a hearing child by the time they get to kindergarten because they've had so much help along the way. So.
That's awesome. And you said that that's your specialty. So is an audiologist actually performing the surgery to implant the cochlear implant, or is that an ENT? Who does that work?
Yeah, so usually it's ENT that specializes in implants. So not every ENT is qualified to do an implant. So generally it's a neurotologist. So it's someone that's strictly the ear. So that's all they focus on.
Okay.
There are a handful, and just think of how big San Diego County is. There may be 4 that do these surgeries.
Okay.
So the audiologist does the pre-evaluation. So we're actually the ones that determine hearing-wise if they're a candidate, and it's pretty stringent for adults. We have to go through hours of testing to make sure that they're a candidate. And then we actually can monitor their responses during the surgery. So we are making sure that nothing is going wrong during the surgery, not performing it. And then afterwards, basically that patient is our patient for the rest of their lives.
Okay.
So we're programming their implant about once a year.
Okay. So one of the things I imagine you check is to see if the auditory nerves are even functioning to send those signals off to the brain.
Yes.
What if someone doesn't have a functioning auditory nerve? I'm assuming they don't get the surgery. Is that right?
Yeah. So what can happen, and this is actually meningitis patients, is the actual cochlea can ossify, so it becomes hard and bony and thick. So the surgeon can't even place the electrodes into the ear to send that signal. So that's the biggest factor we have to look at. So that's why we have to run CT scans and whatnot before the surgery to even make sure. I even had one really rare instance where a child had nothing in there. Like they were born with nothing. There was no ear, no cochlea, no nerve. So in that case, we can't, there's nothing to kind of look up to.
Right, exactly. Forgive me because my specialty is education, not the ear or medicine. The hair cells that are damaged, my understanding is that as someone ages, you tend to lose those high frequency sounds before the low frequency sounds. Is that because of the location in the cochlea for those particular cells and the exposure of those high frequency hair cells to the stimulation over time, just being a little bit about more exposure, so that
that's perfect. That's exactly what it is.
It's like wear and tear over time, basically.
Yeah. So the high frequency cells, if you look, I'm sure you guys have looked at a cochlea.
A little bit, a little bit.
So the it's aligned from high frequency to low frequency. So the high frequencies are more exposed to the elements, and the low frequencies are nice and tucked into this curvature in the cochlea.
Okay.
So any blast or movement of sound is going to hit those highs first.
Okay.
When a patient has, we call it sudden hearing loss or a viral infection or some sort of traumatic event, and that will wipe out the entire cochlea, so you'll see a hearing loss across the board. But mainly age-related, noise-related, things of that sort are going to be high frequency.
Is there any information about why a bacteria might target nerve hair cells and not something else?
There isn't a lot, so I'm going to say 90% of the time on a medical form, we're going to say idiopathic hearing loss, because we cannot really explain. So two people, the same with noise exposure, you could have two people in the armed forces involved in the same blast explosion, same place. One person can have a detrimental hearing loss across the board, the other person is fine. Or the same thing with two cases of bacterial meningitis. One could really affect someone and it could not do the same for the other. So we can't explain, which is why we have not come up with valid treatment for hearing loss besides hearing aids and cochlear implants. We don't have a pill or a shot that we can take to improve our hearing.
So what
we don't really know a lot.
Right. So when someone does have a more mild hearing loss at just a small set of frequencies, let's say, what would you typically prescribe as the best intervention then for that person?
Yeah, so like a mild high frequency hearing loss is what majority of adults occur, and in those cases they're mainly experiencing trouble with clarity of speech, because high frequency sounds are what create clarity. So you can hear the sound but you can't quite understand what they're saying, so that's why you say what. So that patient we would generally fit with hearing aids. A hearing aid, though, that we are able to ventilate the ear canal. So I don't know if you looked at styles, but there's a little style that can go behind the ear.
Okay.
And now that allows the low frequencies alone and only modulate the high frequencies.
Okay.
So we can frequency specific, only improve the areas that we want. And then we reprogram that as the patient's hearing changes every year.
Okay. Now, just a side question. I had heard that sometimes hair cells will be damaged so that they, won't produce a sound or pick up a sound of a particular frequency, and then that frequency might correlate with what caused the damage. Is there any truth to that?
There is some, like just one frequency or a certain place that can happen.
The gunshot or whatever. The gunshot is this frequency, and that's the loss that this person then experiences.
Exactly. And that can happen when someone has, I don't want to say a weak auditory system, but some people do have more sensitive auditory functioning. So like one shotgun explosion can affect just 6,000 hertz. We call that kind of a noise notch, and I see that weekly. I'll see a noise notch that somebody has in just one pitch. Generally, that patient's going to report tinnitus as well. So they're going to have the ringing in the ears. And if I were to match it, it would match right at that frequency.
So the ringing that they hear is sort of like a phantom of whatever caused the problem? Okay, I've heard that before too.
Yeah, and it's basically, there's been damage at that frequency. The brain does not quite catch on to that, so it sends the neural sound like that frequency is still normal, and it's a constant moving.
Okay, that makes sense. That's really interesting. So a question from one of my students that came my way earlier, Sharia, in my third period, asked if it is the responsibility of an audiologist to do work with like an eardrum tear, a tympanic membrane tear. Who do you see if you have that problem?
Yeah, so generally when a patient comes in with a perforated eardrum, so I do all of the testing to determine how severe that is, because certain tears can cause a more severe loss or a more mild loss. Our job is to do all the diagnostic testing and either refer over to ENT, or a lot of times we're working with an ENT in our office down the hall and then send them right over. And then the ENT will either do it's called a tympanoplasty, so they'll actually use kind of a patch and patch up the eardrum where it's been torn, and sometimes they heal themselves.
Okay.
Fun facts, the most eardrum perforations we see are teenage boys. Always.
And is that music related or something else?
Q-tip related.
Q-tip.
A little aggressive with the Q-tips. So
okay. And you told me that your specialty, or your PhD dissertation, or one of your bits of research was on the teenagers.
Yes.
What did you find?
We found that. So on personal music listening devices, we found that boys versus girls did generally listen to their music at a louder volume. And then we were finding an ultra high frequency change in the hair cells within about an hour. So, and that was just in our testing facility with probe mic measurements in the ear. So it's just a small snippet to show that even just an hour listening in the level that they prefer is causing some damage. And I'm seeing year after year more young adults coming in with these noise notches from purely noise exposure. So, and just concerts and festivals and whatnot. I actually was at one this year. I had my little sound measuring device, and it was 110 decibels in the tent. Okay. So just 5 minutes in that environment will cause a hearing loss.
Oh, that's so interesting. My husband and I went to a live music venue a couple weeks ago, and I guess it's just our age, but we both walked in and we had the exact same reaction. Both of us were like, "Woo! It's loud in here."
Oh yeah, I was that cool person with a device.
You have an explanation though. This is what you do. Okay. One other question from a student was just about your knowledge of ASL, or the typical audiologist's knowledge. Is there a requirement for an ASL knowledge?
There is not. So I took 5 years of ASL, and because I wanted to work with patients with cochlear implants, and then in the schools. And so I wouldn't say a good ASL skill, but I can get through a conversation with a student or a parent. And it is less and less. We're seeing patients coming through with ASL due to cochlear implants. Yeah. And a lot of patients that are in the deaf community aren't seeing an audiologist because they are ASL. They're not trying to work an